Okay. So we have Chazari with us. He'll give you the history. So Chazari, do you want to tell them about the patient?
This is a 58-year-old patient who had primary screening colonoscopy. So not all patients undergo FIT here in the Saudi, but you can choose in between primary screening colonoscopy and FIT. This patient had primary screening colonoscopy, and he had a 5 millimeter adenoma in the sigmoid colon that was immediately removed. But then he had this lesion of 20 to 30 millimeter that was flat, lateral spreading tumor in the ascending colon. And we just started the colonoscopy that is in deep sedation with the patient intubated. And now Pradeep is entering the colon under water. You may see that now he is in the cecum. He is using the cap. Pradeep likes to do most of his colonoscopy with the cap, even diagnostic. Even this is not unexpected because half of Japanese diagnostic endoscopies are done with the cap. So don't forget the cap but now I leave to Pradeep for the scope and for the polyp, Pradeep.
So we're using Olympus X1. I've got a 1500 EZ 1500 scope, the long one, which is a standard colonoscope. You know, this colonoscope comes with lots of features, and as we go along we'll try to demonstrate some of those features, but I think we just reached the polyp now. Let me clear some. You can't demonstrate the scope features if the colon is not clean. Thankfully the patient's bowel prep is very good, which is good. I don't know what Abid uses for bowel prep. It's good to know, but in the right colon we always find a lot of mucus, so it's important to get rid of the mucus. Maybe we can do assessment underwater. Okay, so maybe rather than cleaning, why don't I start assessing underwater?
Yeah, I agree, because at the end underwater is also a magnification. But Pradeep, can you tell the audience if you use water or you use saline, and how do you choose also in your center?
So for colonoscopy and for EMR, water is more than enough. If you're going to do ESD, then we need to use saline.
Okay.
Yeah. But you can use saline even for EMR, but it's better to use water. It's less expensive and there's no added advantage of having saline. So what do our panel think? What kind of polyp it is? Morphology?
Here is the issue.
Yeah. So maybe I can change to a TXI to start with. Let's see if the buttons work.
Pradeep, can I just let you know that on the left bottom we had artificial intelligence that was anyway detecting this flat lesion. Now you may see. So it is not true that AI detect only the diminutive polyp, as some people argue. AI also detect flat lesion. It's very important.
So we got TXI now.
Yeah.
It's a contrast enhancement tool which enhances it really well. So you can see the margins well. I find for detection and delineation of margins, it's a very good tool because it gives you a eagle eye appearance from distance. You can see very well. Yeah.
What's the difference between NBI and TXI?
So TXI is a contrast enhancement. So for detection of margin, for detection of lesion. But if you want to then evaluate the polyp, that's not a good mode. You go to NBI. So now we evaluate the surface pattern, the pit pattern. It's mainly with NBI what we're evaluating is the vessel pattern. So I'm looking for any area of focal irregularity.
When you say focal irregularity, you mean glanate tube B. That is when there is a lot of meshed gland that you cannot see anything very well.
Yeah. Oh, okay. Chadri, do you want to explain to them what we're doing?
Yes, in between EMR and ESD, at the end the winner is always the third. And this is a hybrid resection. Pradeep, you are a big supporter of this hybrid resection. Can you tell us why?
So this is a perfectly benign lesion. We have assessed it very well. There is no risk of invasion here. So the risk here is recurrence. So we want perfect resection. So one of the ways of doing it is either we do fully underwater, or you do hybrid resection. I don't like the term hybrid. I call it knife-assisted resection. Can you keep, sorry, slightly, I can't hear them. Knife-assisted resection, where we use the knife to just cut the mucosa and needle out, inject, and then so that what we're doing is we're identifying our battle lines. So we cut in the normal mucosa, needle back, and then we start resecting from there, so there is no residual adenoma left at the margins, needle out.
Yeah, I feel, Pradeep, that there is big evidence that hybrid reduce the risk of recurrence. Now from the audience, they are curious about the device that you are using to do this insulation of the lesion. What are we using now?
So we injected gel effusion with bit of indigo carmine and some methylene blue. And you see on the right side, we already managed to cut the mucosa, do the trimming, so it's ready almost for snare to be engaged. When we have decided that you're going to do knife-assisted resection, you don't have to do a full circumferential incision. You just do a mucosal incision, chop that bit, move on, cut more mucosa, and more.
Yeah.
Yeah. Well, the other point to make is we are in cecum. So the risk of ESD in cecum is relatively high. So you can't promote universal ESD for all large lesions. You need to look at the patient, look at the location, and look at the lesion, what is the risk of cancer in that lesion. And based on that, you decide what you want to do. Here, I feel that I don't think I can justify full ESD. We've done plenty of LSTNG here, where you would justify the risk of perforation because the risk of cancer is very high, whereas this lesion, the risk of cancer is very low. So there's no need to do all that.
Pradeep, you are using the dual knife to do the incision, and you are also doing it under saline. So there are also advantages in doing the incision under saline.
The advantage of staying under saline is you're not thinning out. The mucosa is already very thin here. The muscle layer is already very thin. If I inflate it with gas and then your knife mistakenly goes a little bit deep, a stretched muscle will perforate much quicker than a relaxed muscle like this.
Very good point.
So I think in right colon, underwater use of knife, use of snare has another added advantage is that it improves the safety despite injection. Now you see there is a lot of fat in this mucosa, submucosa, and see how long it's taking from a knife to cut. It's because of the fat in the submucosa. This is a common occurrence in this region.
Pradeep,
just a question: if you have a big polyp if you have a polyp in the right side,
knife back, knife back.
Do you prefer pediatric colonoscope for
inject
for retroflexion and this, or you prefer adultoscope?
I prefer whatever scope is available. I think it makes minor difference whether it's pediatric or adult. If you already know, stop, watch the screen. If you already know that you are going to do ESD, you will need retroflexion, inject now, then maybe it's a good idea to go with a pediatric scope, inject. If you are not planning to do that, then there is no added advantage. Pediatric scope has a smaller channel. If you get a bleed, if you are underwater, you need to suck fast, and you won't be able to do that with pediatric scope. So that's why there's no need to use pediatric scope. Okay, so can I have a 15 millimeter snare ready, please? And somebody needs to change my diathermy setting to EMR again. Inject, please.
No,
And stop. Let's get the snare. Oh, Ahmed is here. Okay, good. I have a very specialist technician.
my God.
Okay, come back, no problem. Yeah. Yeah, they can go to another room. We'll just start.